our HOD, Professor Suresh sir, and Professor Selvaraj sir, for giving me this opportunity to stand before you to discuss something on abdominal examination and important cases of the abdomen. So you all know, so the recent ad on Valentine's Day, there's a Cadbury's 5-star. Whenever uncle joins, the tempo goes down. I hope the tempo does not go down here because we both are uncles. But we are having a lot of experiences. So we are here to raise the tempo, to face examination with more courage and good attitude. So that is our main aim. Right? So please feel free to interrupt us. So whenever you raise question, so that make us very happy. So that make us this session fruitful and useful. So that is my humble instruction to you all. So a small introduction about this abdomen case. Whenever you get abdomen case in the examination, maybe in university examination or formative examination, so you immediately go to your skill test and skilled CRMI, skilled PG. Sir, abdomen sir, no sir, no sir, no sir. So we want CV sir, CV sir. Because CV is the cardiac, CV is always a superstar like Shah Rukh Khan, Nayanthara or Rajinikanth. Because it earns so much of fancy and passion from all disciplines of medicine, all UGs or PGs. They are always wanting this CVs. Abdomen nobody wants. Why abdomen nobody wants? In India? Have you ever watched this Christopher Nolan movie? You have heard about this Christopher Nolan? Recently I watched one movie, the Tenet movie. Anybody watch? No. So I watched the movie for one full day. I'll see one scene, I'll stop, read the subtitle, and then go for the next chart. So this goes on, went on 24 hours. Even then I was not able to understand. So just like that abdomen examination also, you will not be able to understand because you will have only two findings, hepatomegaly and splenomegaly. You have to use your brain to fetch out the diagnosis. So we will start the session. Over to my co-chairperson.
Rajavel is a very good clinician. Make use of his clinical knowledge for your benefit. I'm here to just passively person. We will stay with Rajavel sir. He will take over for the sessions. Thank you.
So I come with so many chocolates. Right? Sweet ready kondadu. Okay. So 10 to 15 chocolates are there. So I'll see who is going to claim all these chocolates. The presenters. So not only the presenters, you can even answer. Okay. Right.
Respected dignitaries on and off the dais, my dear friends, good morning to one and all. Myself Lakshmi and this is Mahima. We are here to discuss on the examination of the gastrointestinal system. So first, we have a thorough history from the patient, and after getting the history, we have come to a conclusion that the system that need to be examined is the gastrointestinal system. Before moving on to the systemic examination, first we will do the general examination. First we see the built-in nourishment of the patient.
DOAP. Examination.
First, we see the built-in nourishment of the patient. We assess his height and weight and check the BMI. Then move on to the examination of bladder. Bladder can be found in the lower parietal conjunctiva. Next one is jaundice. Jaundice can be
Anemia, what are the other areas you look for anemia? Okay, one is a palpebral conjunctiva, right? Number 2 is a tongue, right? Number 3, not palate, not necessary. Number 3, over the palms and the nails also. Okay. So what are the additional information you can get from all these areas? Why you are looking at other areas also, not only in the palpebral conjunctiva? Anybody? Chocolate? Pardon? Yes, very good. Severity, right? Severity can be assessed by looking at the palms and nails, and additional information about the type of anemia also, right? Type of, you can look at the leukoplakia, brittle nails, and spooning of nails. There's the chiroplakia. You can have some information on this iron deficiency level in there. Okay, jaundice.
Another point is regarding another additional finding is pigmentation creases. Suppose patient is having severe pigmentation creases with anemia, and also he has lemon yellow discoloration of the eyes or sclera. So what is the meaning of this? Whether lemon sclera and the creases are showing pigmentations, black pigmentations. No. It's a type of hemolytic anemia secondary to vitamin B12 deficiency. It is one of the basic bedside finding. It makes the diagnosis of B12 deficiency. Pigmentations, but not nodular pigmentations, plain pigmentations. Where do you get small nodular pigmentations in the creases? Where do you get that? Nodular pigmentations, very tiny nodular pigmentations over the neck region, over the creases. You'll be able to see, including elbow, including the knee joint. Not infections. No. It's a type of problem which you see with insulin resistance. Sarcoidosis negligence, another finding you see from the pigmentation of the creases. It starts from here, neck, elbow, and knee joint also. These are the areas you can look for, depends on the severity. So anemia is concerned in abdomen case, you can also get mild splenomegaly, mild hepatomegaly also. It's a sign of hemolytic anemia, but you get pigmentations in the creases, very important. Both palmar crease and the dorsal crease.
Okay, move on.
Next we'll see clapping.
All the grades. Grade 1.
Thumb and middle finger, and then fluctuate using your index finger, one of the index finger, and you can feel it with the other finger.
Ideally, you can do the DAP also or PAP. I want to go for DAP. The middle finger which you are holding for the, you can hold it. Yeah, index finger. Press on the tape.
Okay, grade 3.
It can be found out by Shanrock sign. You can ask the patient. If the diamond shape space is obliterated, then you will have grade 4 is hypertrophic pulmonary osteoarthropathy. Along with clumping, the person will have a joint pain, and you can ask for joint pain.
So, hold the limb like this. That is from the radial side like that. You have to press and move towards it. Okay. So, you have to press. You feel for the thickening, periosteal thickening. At the same time, you have to look for the reaction of the patient for tenderness. So, periosteal thickening and tenderness will be the hallmark of grade 4. Okay. So, in what way this clipping is important in GAT?
GIT, clumping can be found in case of inflammatory bowel disease, primary biliary cirrhosis,
Okay, very good.
then hepatocellular carcinoma.
Right, very good. Okay, move on.
Better to avoid the term primary. It's hypertrophic osteoarthritis.
Osteoarthritis.
There is no more pulmonary. It was thought to be because of one pulmonary disease or brain. Now it's any disease producing clumping having a grade 4 will have a periosteal reaction. So basically periosteal reaction.
Next point in general examination.
Next we'll check for cyanosis.
General cyanosis and
General cyanosis can be defined using nails or maybe a rope. Then central cyanosis can find over the
non-state scientist person's hemoglobin is 2 gram per deciliter. 3 gram.
Greater than 5
Less.
5 gram.
More than 5 grams to be there. Why?
Reduce hemoglobin.
Reduced hemoglobin. What is it? Student demographic word. I have to create my own sentence or meaning or come to the answer. Okay, let this be a homework for you.
Then we have to look for the lymphadenopathy. You have to stand on the side of the patient.
General principle of lymphadenopathy always stand behind the patient. You know the basics. But surgical case, medical case doesn't matter.
Look at the regions of lateral, preauricular, postauricular,
Which is the other.
preauricular, postauricular,
Yeah, correct.
then for occipital, cervical, then for submandibular and submental. Sub
The first one what you show is jugular diagnostic. That's the mandibular part. Your finger like this, insinuate your finger, look for this. The submental part is single finger and try to palpate for the submental. Mental is here. Right? Mental.
So what is the importance of lymphadenopathy in GAT? You can diagnose. Number 1, lymphomas. Okay, TB, tuberculosis, lymphomas. Okay, very good.
Then in case of supraclavicular lymph node versus any GA malignancy can be suspected.
Okay. Any other infectious disease that presented with generalized lymphadenopathy? Causes of generalized significant generalopathy. Number 1. Okay. That is somewhat common. HIV, lymphoma, leukemia, and disseminated tuberculosis also. Okay, proceed.
That will look for rituals. Can we show that? Is it correct?
Between two heads of surgery.
It is the place we are supposed to look for the rituals. It is left side. The space between the two heads is going to be rituals. So what is the name of right side?
Apollo.
Apollo. Could you very much challenge it, man? You are rocking in the back. Sit. Good. What's the name of the right side? Okay, what is the Henry's notes? Okay, homework. Yes, go ahead.
Next, in GA examination, we have to see the fetal edema and state.
So where will you look for fetal edema?
About the medial malleolus. Medial malleolus, about the medial malleolus, we have to press for 30 seconds.
Okay, right, proceed. Fetal edema over then.
Then in GA examination, we have to look for the signs of chronic liver disease. There we will look for in the skin and nails. We can look for regular whitish nails. Then clumpiness already. Then you can look for palmar erythema. Palmar erythema is usually found in the renal and hyporenal remnants. Renal and hyporenal remnants. Then you can look for spider needle. This is usually found on the above the nipple area in the anterior and posterior part of the chest and head and neck regions. These are found. There is a central arteriole with peripheral vessels radiating.
DD for spider anyway. Very good. Venous star. Then Campbell Morgan spot.
Senile angiomas. That is called as Campbell-Morgan spots or senile angiomas. Then commonest lead in a patient with a chronic liver disease. Petechiae purpuric spots. So those differential spots. Okay, what is the size you are expecting? The site you say size. It can be, yeah, it can be few millimeters to even centimeter. You can get a spider maybe up to 1 to 2 centimeters also. Okay. Yes, you should know how to demonstrate. What is the method?
So using the thing,
Or otherwise, just a method to
use like
glass like method or penny method. Don't injure the spider, very, very important. Don't use the sharp objects. Penny is not going to sharp, it's a blunted one. So always try to do that. Okay, very important. Okay.
Okay, proceed.
next we can look for
You said skin, but you didn't say anything about the skin. You mentioned about nail color, all those stuff. Skin nature, bruising can be found, anything else. What type of chronic liver disease? Scratch marks, anything else. Pigmentations can be there. Anything else? Skin can be very much delicate, what is called as described in the previous years, paper money skin. The described as a paper money skin. Thus compared to the US dollar, it's called as paper money skin, very much thinned out skin. Because of multiple endocrinological changes, fat loss is the two important reasons for this type of changes. But all the skin changes you're expecting. So bruising is very important point, yes, we're not talking about the decompensated liver disease. Okay. Go ahead.
moving on to the endocrine disease.
Where to look for? Madam was telling about.
Usually it is found on the ring and little fingers.
Yes, that's the area where you supposed to. Where do you look for? Yeah, but which area? The palm. Here it's going to be not like. This is the point you're supposed to look for. Then do this, then go for the little finger also. These two are not changed. First one to start with, it always goes like this, then it comes. Starting here, this is the area supposed to look for. Then goes in here. These two areas usually not in front. Okay. Yes.
Then we can look for endocrine disease like gynecomastia in males and atrophy of breast in females.
The madam was mentioning about how to differentiate from the fat tissues. Okay. Yes.
Then loss of hair in the chest area, axilla and over the face. Then there is lymphaticus, that is a sweet breath of the patient.
Yes.
Then flapping tremor or acidosis can be demonstrated.
Demonstrate flapping tremor.
Cause the patient to extend his arm and dorsiflex his wrist and then spread the
Spread out. Good,
fingers.
good. So draw your plus and spread out. The fingers to be spread out. So what do you expect? This is positive. The tremor. What do you expect? How the patient will demonstrate or will express the problem of
Myoclonic collapses.
no, when you expect the movement in the wrist joint, MCP, PAP, BAP, or finger movement like this, what do you expect? Movement at the wrist and the MCP joint, not at the IP joints. Most of the time, the sternal tremors or alcohol-related tremors don't interpret that as the flapping tremor. Very important. Always joints, two joints importantly, and alternate flexion extension movement is going to happen. But the postgraduate, why it's happening? And what is the problematic side? Is it a flexion or extension movement? Go read about that.
What's the other cause of flapping tremor? One is hepatocellular failure. Any other cause? Respiratory failure. Right, proceed.
Any systemic organ failure will get this. Systemic organ, any systemic organ will get this. Renal failure also. Okay. Yes.
Then go down.
Then we can look at the oral cavity examination.
Before the parotid.
Parotid gland swelling.
It is not a sign of liver cell failure, it's a sign of alcohol. Don't include, but you are supposed to look for. Also look for what is the type of skin and the face look like. I already mentioned about weight and height, BMI, but this specifically about the liver disease. What do you expect this part to be? Both the masseter part and temporal part goes into complete waste. Always go to the maximum best. Okay, that all is supposed to look for.
The oral cavity exam.
General examination over. Anything missed? Hair. Testicular atrophy. Anything missed? Pardon? Markers. What markers? No. No chocolate. Any other markers? That is very important in abdominal system, GET. Nutritional markers. Markers of malnutrition or markers of anthropometry. You must never forget to mention it, right? So what are the markers you look for? Markers of malnutrition, signs of avitaminosis, starting from eye, white blood spot, cheilosis, angular stomatitis, pigmentation over the neck, and then BMI is very important because so much all the patients of GAT, there is a reversal disorder, will have emaciation or malnutrition. So you must measure BMI, right? Height weight ratio. So all the calculate BMI, you know, right? BMI, and then any other markers of anthropometry that will tell you about the nutrition of the patient apart from BMI. Very good. Mid-term circumference. Okay. ரொம்ப நேரம் சாக்லேட் கொடுக்காம வச்சிருக்கேன். Right. No. Mid-term circumference, then excellent. Waist hip ratio, right? Waist hip ratio. How to measure waist? How to measure hip? Which is waist? Which is hip? Waist is the midpoint between the costal margin and the iliac crest. So that measurement is waist. Hip is the measurement around the both iliac crest. So you have to take two measurements and take the ratio. This is a very important marker, not only in GAT disease, also in the coronary disease. It is a marker of coronary disease, right? So mid-arm circumference and skin fold thickness, and then BMI, then all the markers of malnutrition which I just enumerated. So all these markers you must mention in the GAT examination. Apart from that, one other thing is a must. What is must? Anybody? MUST, must. Must. So homework. It is a malnutrition universal screening tool, and there are 3 criteria. Please go and read. Proceed. So proceeding to abdominal examination.
Oral cavity examination, we see the loose colony and angular stomatitis. Then oral cavity. You can look for any dental caries, then ulceration, or any discoloration disease, if the patient is prone to tobacco chewing, staining.
Any information you can receive from the tongue?
Tongue based on color of the tongue.
Okay.
Or any cavity, like cavity assistant acid.
Right.
Vitamin B12 deficiency shown at leafy tongue.
Very good.
Then magenta tongue vitamin B12.
Very good. Okay. Proceed.
Next is
Examination of your abdomen. Right. Number 1. Number 2, you have to explain the procedure to the patient. What you are going to do. So I am going to inspect your abdomen, I am going to palpate the abdomen, or I am going to percuss, or I am going to perform the knee jerk, like that. You should get consent and explain the procedure to the patient, and you should give assurance to the patient. It won't hurt. If it hurts, please tell me. So these are the basic courtesies. This carry marks in the every ASCII session. This you should never forget. Okay. Then only you have to perform the ASCII, the particular part. And then for all ASCII session, proper positioning of the patient is very important. For example, abdominal examination, this is a supine position, right? JVP 45 degree, apical impulse supine position or 45 degree, like that. For every ASCII session, every examination, positioning of the patient, and then positioning of a particular area. When you are going to look at the abdomen, inspection of the abdomen, you have to strip the patient, right? Up to hip. You have to keep the patient naked. So that is also another point. Then only you have to proceed to the examination proper. Like proceed.
Except for dilatation of veins, for arrest everything, patient should be in supine position.
So expose abdomen completely.
From CP sternum to preferably till pubic symphysis.
Okay, no problem. Proceed.
Then we should look for the skin abnormalities. That is for the shape of abdomen, then the flanks, whether it is free or full. Then we should look for
First is the shape of the abdomen, right? So what is the normal shape of the abdomen?
scaphoid, flat, then
Or protuberant.
generalized distension is seen in case of flatus and pregnancy, then food bladder,
Fluid.
fluid, constipation.
That is not generalized distension. The generalized distension only you will have in fluid. Fluid is the generalizer. Bladder is localized. Bladder, pregnancy, or you said constipation. Why you are having flapping tremor? This is the first presentation on stage. No problem, right? Be cool. So whenever you face examiner, the first mantra to get a pass is you have to be cool. You have to tell whatever you know, that's all. If you do not know, gently say, sir, I do not know. The examiner will not come in the intention to fail you or in an intention to always harass you, right? So they will ask questions from your points only. What you are telling, they will start asking questions. So you can drag the examiner on your way. That is depending upon your intelligence, right? So whatever your area, or what is your area of strength, you know. So you drag the examiner along your side. Okay, proceed.
Then we have to look for the skin. We should see whether it is any discoloration is present.
Very good.
Umbilicus, around the umbilicus, it's colon sign. Then discoloration over the abdomen, that is grey color sign. It is seen in pancreatitis. Then we have to look for any purple striae. That
Okay,
is
striae.
Cushing's syndrome. Then stria gravidarum or stria.
What is stria albicanthus? It is normally pregnancy, right?
Erythema abigne.
Chronic pain in the pancreatitis.
What is it due to? It's erythematous changes. Is it clear? It's not clear. Yeah, this one. It's not clear. Yes.
It is seen in
It's
the
erythematous changes secondary to application of heat waves or heat material or hot water, something like that, kept over that makes a change in the skin. Okay, it's called as erythema ab igne.
linear occurrence in case of
What else you see in the section?
then we look for
Discoloration, striae, pregnancy, then
then we have to for sequences. Then movements with respiration of all organs. The movements will be reduced in case of generalized peritonitis because it's silent, it shows silent abdomen. Then we have to look for any visible mass, visible peristalsis.
before that, very important thing.
Dilated.
Dilated veins. So that should be the first point. Dilated veins. This VGP, VEP all are surgical. Okay. We are physician. Dilated veins. So what is the importance of dilated veins? According to the area. It is around the umbilicus. Right. And if it is over the side, that's the flanks, it is IVC obstruction. Over the chest wall, SVC obstruction. It's very simple. Then. Okay, dilated veins, movement, color, discoloration, everything over. Scars.
Can be seen in TB and Crohn's disease. Then
Okay, but then a flanks.
dilation of peptides.
Okay.
It is seen in the postpartum and then intense ascites also. We have to tell the patient to lift off.
What is the importance of divarication of recti? Why it is to be seen? Hernia. Divarication of recti?
Divarication of rectum.
gap seen between the
Okay, ma'am. Why it is to be seen? What is the clinically important? No, it's very simple. It just says it's a chronic ascites. That is, ascites is chronic. That is very chronic. So if it is given as a short case, you do not know the diagnosis, right? So you do not know the duration. With the duration, you can make the diagnosis or you can alter the diagnosis. So if you do not know the duration through the history, so these are some of the signs where you can say whether it's acute ascites or chronic ascites. Divarication of recti, and then other things are there. We will see in the palpation. Inspection. Anything else apart from divarication of recti? So you have to comment whether the abdomen is tense or not, right? Okay, then over. Anything else seen in inspection?
Pulsatile.
Pardon? Okay.
External genitalia.
Position of the umbilicus.
Retracted and
Inverted or everted.
If it is everted, it denotes tense as it is. Then umbilical hernia, it is seen in the gross as it is when the abdominal wall is lax.
That also tells you about the chronicity. Everted umbilicus, right? Umbilical hernia.
Umbilical node is seen in the system medullary nodes, that is suggestive of metastasis 3 cancers.
Okay, that is somewhat rare. Right.
We have to see the distance between the CT sternum and umbilicus, and distance between the umbilicus and subpubic symphysis, and the ratio between both should be 1.6. If the ratio is increased, denotes that the distance between the CT sternum and the umbilicus is increased. That is the upper abdominal mass and ascites it is increased. If the distance between the umbilicus and pubic symphysis is increased, it denotes pelvic mass. And in case of females, it denotes ovarian.
Okay, go to palpation.
Palpation. First, we'll do superficial palpation
For what?
to identify the pain,
Process of warmth and pain, tenderness.
swelling, and rigidity. For that, we'll start from left iliac fossa, anti-clockwise direction. We should reach till right iliac fossa, then pubic symphysis region, and end at umbilicus. And the fingers should not be too rigid, it should mold in the abdomen. And the fingers should be straight, and the flexion of metacarpophalangeal joints should be there.
Okay, and then deep palpation.
First, we'll go to liver palpation. It starts from right iliac fossa, and
What is the position of the patient? So in supine, flex the knee.
flexion of knee and hip joint.
காலை மடிச்சு வச்சுக்கோங்க, ரெண்டு காலையும் மடிச்சு வச்சுக்கோங்க. தலையை லேசாக அந்த பக்கம் திரும்பிக்கோங்க. வாயை திறந்து மூச்சு எடுத்துக்கணும். ரைட், திஸ் இஸ் த இன்ஸ்ட்ரக்ஷன் யூ ஹேவ் டு கிவ் டு த பேஷண்ட். சளி இருக்கா? இருமலுக்கு சிகரெட் பிடிப்பீங்களா? ஸோ இட் டர்ன்ஸ் டு பி ஆர்எஸ் கேஸ். நோ, கையை கீழே வச்சுக்கோங்க, சைடில் வச்சுக்கோங்க. ஸோ எக்ஸ்பிளைன் த ப்ரொசீஜர் டு த பேஷண்ட். வாயால் மூச்சு இழுத்து விடுவோம். அப்படிதான், ரைட்.
And we have
So how you should perform?
the radial end of the radial border of the index finger should be parallel to the costal margin, and we have to advance during inspiration and feel for that.
What is the very, very important point? While during inspiration you have to press, right? So expiration la press பண்ணக்கூடாது. Inspiration you have to press. Then only you can feel the liver.
We have to reach till the right costal margin.
If it is not palpable, what will you do?
Usually not palpable, sir, but it might be palpable also. If it is palpable, then we should measure the distance from the costal margin.
To identify minimal hepatomegaly, what will you do? Insinuation. Insinuate your fingers into the costal margin.
Then we should describe that if, for example, if it is palpable 3 centimeters from the lower border of the costal margin, we should tell that at the mid-clavicular line it is palpable 3 centimeters lower the right costal margin.
Okay, what is the dipping method? How will you perform? What is the use?
The dipping method is performed in ascites, sir. It is used. Right hand should be placed over the abdomen, and left hand should be placed over the right hand, and flexion of metacarpophalangeal joints. We should, when we do this, the fluid, if fluid is present, it moves, and we will be able to palpate if there is any.
So dipping method is done in case of massive ascites, right? When the abdomen is tense, you have to perform this dipping method. So you have to like this, right? Both hands, one over the other. So you have to keep over the abdomen. When the patient is doing inspiration, you have to give a tip, right? This like tap, just a tip or a tap. So this tap will displace the fluid At the same time, the patient is doing inspiration, so the liver will come down and touch your finger. So the dipping method is very important. You should know how to demonstrate in the examination. Okay. Now spleen.
Spleen, it enlarges in the diagonally towards the right iliac fossa. So the palpation should be towards the left hypochondric region. So this also
Starting from the right iliac fossa
to the
towards the
left
left costal margin.
costal margin. Here also the fingers should be parallel to the left costal margin, and during inspiration we have to insinuate during the inspiration, and during expiration you have to advance.
ಎಲ್ಲ ಮುಚ್ಚಿಟ್ಟು. So even after reaching to the costal margin, you are not palpating the spleen. What do you do?
You have to use the bimanual method, sir. Use the left hand in the posterolateral surface and tell the patient
Right lateral position.
right lateral position, and we have to press the left hand
Press.
to limit the movements of the lower border of the costal
Give a
margin.
support. Okay. Give a good support.
Then we have to try insinuating. Even if we didn't feel, the spleen is not palpable, sir. 2 to 3 times if it is enlarged only, spleen can be palpable. Then that's it, sir.
Percussion method.
Then palpation of
Any other palpative finds you want to show?
for palpating right knee, we should keep our right hand over the right lumbar region and the left hand over the right loin, and tell the patient to turn. And your left hand should push forwards and the right hand should push backward, inward and upwards. And we have to feel for the knee. It can be palpable in the lean patients. If it is palpable, we should tell that kidney is palpable by bimanual palpation, and it is ballotable, sir. Ballotment means when we push from one hand, we can be able to feel from the other hand.
Usually, normally, lower part of the kidney alone, right side alone is palpable. Very, very thin individuals. Otherwise, it's not usually palpable. Okay.
Then for palpating left kidney, right hand should be over the left lumbar region, and left hand should be over the left loin region, and tell the patient to turn the right side. Here also the same procedure. With right hand we have to palpate inwards, upwards and backwards, and using left hand we should palpate forward, push forwards, and if we are able to feel we can't able to feel the kidney in case of anything. Only if the kidney is lower positioned or enlargement is there, only we can feel.
But you should know the difference between the bimanual palpation and the ballotability.
Okay. Percussion.
Percussion, we start with the percussion. Over the sternal angle is at the level of the second rib. This will be the second intercostal space. Starting from there, we start our percussion along the orbiculateral line. And, third intercostal space. Fourth and
Sound produced. Okay. So you should keep one finger, only one finger. You should raise all the other fingers. You should tap the distal joint, right? Over this. Okay. ரெண்டு தட்டு தான் கதவு தட்டுற மாதிரி தட்டிகிட்டே இருக்கக்கூடாது. Only 1 or 2 tap. And it should produce some sound. Right. Then you should move down. So you have to ensure that your finger is in the space or not. It should not be over the rib. Okay. ending point also you have to confirm for further percussing. Okay. What about tidal percussion? What is tidal percussion? What is the use of tidal percussion? What is the aim of tidal percussion? Come forward and answer. Condition you can differentiate. Mainly to differentiate between the lung pathology and the upward enlargement of the liver or whether it is a lung pathology. Okay, this the main aim is to differentiate. Normal liver span 15, 30, 30 centimeters.
Then spleen percussion, first method is
Not necessary. Any other thing in the liver cell disorder percussion regarding fluid?
shifting
Minutes.
shifting minutes, you can do it by first
So you should know how to demonstrate shifting minutes. Definitely you will be asked with the examination.
first you keep your finger at the midline level and then move on to the laterally towards the flank.
Okay.
Then at some point if dullness is present,
Notice.
then you keep the finger at the
Same place.
same level itself and ask the patient to shift to the opposite
Opposite
direction.
side. Then
Then wait for 30 seconds and again if the
wait to wait. Shift to the fluid. Then
wait for 30 seconds.
again.
Then
Focus on the same. Dullness. Now what will happen?
becomes resonant.
It will be resonant.
then you can move to the opposite side. Then examination fluid drill. Ask the patient to keep this ulnar position right here.
Or you can seek the help of the assistant also, right? Will do.
And using one hand place it over the one lumbar region and using the other hand you can give it back.
Importance of shifting helmet and quick grip.
Shifting happens resulting the
Two letters.
differentiate massive fasciitis and dense.
So one important thing you forgot, in palpation, you have to confirm the dilated veins and assess the flow. How you
With heart-based sensor, that is, we have to ask the patient to stand. Ask them
Perfect.
dilated vein is palpation.
You know it.
if something is present, we have to use the index finger and compress the vein and then stretch over.
It's called bleeding, right?
Then we have to remove one finger and see the direction of flow, and we have to repeat the procedure and take the other finger. We have to note in which method the flow is rapid.
Which direction?
Which direction the flow is more and rapid.
The blood vessel is filled with blood.
In portal hypertension, the flow will be above the umbilicus, it will be upwards, and below umbilicus, it will be downwards. And in portal vein thrombosis, it will be above umbilicus, it will be downwards, and below umbilicus, it will be upwards. And in IBC obstruction, both in above and below umbilicus, it will be towards upwards, and in SPC obstruction, it will be downwards.
So port hypertension is normal or abnormal? No, port hypertension is abnormal one. The way of blood flow direction is a normal one, or otherwise what is happening?
Normal.
So normally the blood vessels flow or blood flow will be away from the umbilicus. That's what she's trying to say. And is exaggerated normal flow in case of portal hypertension. Whereas the direction of the blood will be towards the umbilicus is going to be portal vein thrombosis. The lateral veins from below upwards is going to be SVC or IVC obstruction. And another area you can also look for the back veins also. Okay. Auscultation. What are the things you like to look for? How to look for vowel sounds? But never keep on changing it.
Then in case of increased vowel sound,
No, deal with that. Next point, anything else you want to auscultate? Brui, what are the areas you look for the brui?
epigastric region can look for
Artery. No, liver disease. If you're venous brui, which we can look for cranial bone contacts syndrome side. Okay, you can look for then
renal stenosis.
liver. Splenic brui also you can look for. So any abdomen case you are supposed to look for, you should know. Look for the bubble sound is a must. Then followed by your the venous hum or your brui, liver brui, and this rub also you can look for both the sides. Then in addition to that, if you want to examine, you can look for the renal brui, all those stuff, iliac brui, all those signs are there. But in any case of common exam case, you should do this. But iliac brui or your renal brui, if you are not auscultating, nobody will find fault with you. But if you are not mentioning about these two and this, it's a must. Okay. Especially dilated veins are there.
No doubts from the audience. You can ask any question related to examination. Sir, how to palpate liver, how to palpate spleen, like that. Please raise questions.
I will ask about the process. 3 doubts, sir.
Yesterday also Sir was only asking.
For them only, sir. Because on the giant or the abdomen process, sir. So what doubt is, suppose you are doing whether you are putting the dominant hand above or non-dominant hand above.
Only dominant hand above, sir. You have to give force. So dominant hand always up.
The other,
This is a passive hand.
no, sir. This one, for the explanation for this one is, I also feel that the dominant hand should be this. The explanation for the left hand above the right hand is that when you press, the organ will come and touch the left hand more easily than the right hand. Such explanation is there, so I don't know, sir.
What is the reason?
I don't know, sir. So second is, by palpating the kidney, whether you are in the supine posture or you want to change only in the supine posture. So third, to Saravanan sir. So last CME, you have demonstrated very beautifully one shifting nullness. That is, when the dull knot comes there, then you are changing into the supine posture and demonstrating the pursuant knot. Can you
There are
demonstrate?
3 steps of looking for liver span, 3 steps of looking for shifting dull knot also. So whatever the situation is going to be, this fluid distension is there. Very simple methods, because it's called a shifting dull knot, meaning that you're supposed to show dull knot first, then try to show that it is changing into the resonant knot. Once again you're supposed to show that it is coming back to dull knot. So basically you're going to have a fluid collection. You're going to start from this epigastric region, ideal one to start with, and you're going to come to the level of umbilicus. Then moving from this point or center point, change your fingers. You are trying to show it this way. Ideal want to go for this percussion, followed by this direction, change your till the area of dull knot. Once you reach the dull knot, maybe you can one step down also you can go down to find out the dull knot is confirmed that in that area. Followed by ask the patient to turn to the other side you'll be able to demonstrate after a few seconds of waiting, you'll be able to demonstrate resonant note after the shift of the fluid from this area to the left side dependent area. Then make the patient to neutral position.
Sir, you can demonstrate.
Yeah. I'm doing from this epicase region to the umbilical level. Now I'm going to move laterally till I'm getting the dull note. I'm going to go one step down. I'm demonstrating once again dull note on the side 3. I'm just going to wait. Pull. I'm going to just wait for a few seconds. I'm not changing my finger. Now I'm going to demonstrate resonant note after a few seconds of waiting because of shift of fluid. Now I'm going to make the patient to flat now.
This is what the sir was doing.
Now I'm going to wait for a few seconds once again. Once again the back of the fluid to the same neutral position or the usual position. I'm going to demonstrate dull note. So the position of the finger is not going to change. It is only the patient is changing his position. This is what the classical method of demonstrating shifting dull note. Whereas liver span, there are 3 steps or 4 steps to be followed to identify the liver span. And the title Prof sir was asking about important aspect is that one. Also can also identify the upper margin of the liver also. So moving from this on the midclavicular line, the liver span slightly differed at the midclavicular line. The 12 centimeters or 30 centimeters were only the midclavicular line. The lateral part or mid-sternal part of the liver span is slightly shorter. Also you should remember that because left side of the lobe alone or left lobe alone is contributing the mid-sternal part or that liver span. Okay. So moving from this, the midclavicular line, I am going to get the upper margin of the dull note now or the superior margin of the liver. I am going to confirm that I am dealing with only liver dull note by doing a tidal percussion now. Ask the patient deep inspiration, the area is percussion, now it become dull will become resonant now. It is making myself confirm that I am dealing with the superior margin of the upper margin of the liver now. Now what I am going to do that is, I want to confirm the inferior margin of the liver or the lower margin of the liver. Because the rule of Perkins says to you that always starts from resonant to dull note. So we are trying to identify solid organ measurement or the span by identifying the upper margin and the lower margin. It's a fixed organ. It's not like a hollow viscous where we have the floating or moving organ. It's going to be fixed organ. I'm going to demonstrate the first upper margin or superior margin. Followed by I'm going to go down from this level. I'm going to move upwards to the level of dull note. In a changed the liver span or the liver, you will be expecting the dull note to be in the only costal margin. Suppose liver is enlarged or liver is shrunken, you are expecting the dull note, this point will become slightly higher level, it is shrunken, it's expanded, it will go down to this slightly 1 or 2 space down also. After identifying this point, I am bit of confirm that the lower margin or the inferior margin, I am confirming the superior margin also. Already confirmed with the tidal percussion, 3 steps. Next time what I am going to do is, the uniformity of the dull note is maintaining in between the superior and the inferior margin. I am going to confirm by focusing from this point to this point. Almost everything is confirmed that I am dealing with a solid organ. Sometimes to your surface you might be seeing a liquid cyst also can be there, which will give you some sort of wrong ideas. To overcome that only we are going to do that, starting from the identifying the superior margin, then going down to the level of inferior margin, but inferior margin is identified from the right iliac fossa below upwards. Above downwards superior margin. What you are trying to follow is a percussion method of clinically identifying the organ size, solid organ. You are trying to follow the rule of percussion also. Then followed by you are trying to do that, then try to measure the distance between the superior margin and the inferior margin, identifying the total length of your liver span. That's the best way to do that, liver span also. I hope I answered your question.
Any concerns about the splenic size measurements? Because new Harrison also it is written something different. So for the UGs, for the examination purpose, how will you say that from
the
that
measurement
also,
usually
new Harrison also it is different.
The mid-axillary line or the 10th space is the axis of the spleen. 10th rib, not 10th space, 10th rib is the axis of the spleen. Because usually occupies 9, 10 and 8 or 11. This is the space of your spleen. It's going to be axis of the 10th rib is the axis of the long axis of the spleen. So you're going to start from here. What are the space you're going to go? I think it's a similar way from the costal margin.
Old teachings.
Yeah. Costal margin, you're going to measure.
So, Addison they are telling take an arbitrary point 7 centimeters from that is not needed.
Usually
Only
start from
bandage.
the costal margin, conventionally going to go for the diagonally going to measure the distance from the level of costal margin towards the umbilicus or spinoumbilical. Going to do that. And there are other methods you should be familiar with, the Castell's method and Middleton's maneuver and the Nixon's method. Okay, these are 3 methods to identify. They are also knowing about the hooking method, both applicable for liver and the spleen. These are all the few methods. These are all for the traditional way of teaching and should be a bit familiar with. You are answering all the questions, probably examiner might ask you about these questions. If you are answering, then you will get a good marks, very good marks. And easy for remembrance is anterior axillary line is Castell's method. Okay, mid axillary line is going to be what is the area? Drops area measurement distance. And your posterior axillary line is going to be Nixon's method. Okay, so Castell's, Trops and your Nixon's method. Nixon's method is the distance of from the posterior costal margin. It's usually 8 centimeters usual, but the dullness is going to be more than that. It is going to be definitely enlarged spleen at the posterior axillary line here. Okay, whereas anterior axillary line it's going to be the Castell's method. And similarly using the mid axillary line for the top space. Okay, and all of you should know about the Middleton's maneuver. You're trying to palpate the spleen, asking the patient to
Left fist
keep
out.
keep the fist at the back and try to push at the costal margin, lower costal margin. Pushing like this. Okay, loose. Okay. Ask the patient lie down comfortably, slightly. Try to push here and try to palpate. Instead of the examiner pushing, that's what she was trying to do. The pushing, pushing like this. The method is followed by the patient is instructed to keep the hand or fist here and try to palpate. It's called as Middleton's maneuver of palpating. Another important, you should know about this and the abdomen case, the renal angle. Very important. Usually teach the students as 9 quadrants. We always tell the students to follow 13 quadrants. Okay, always follow 13 quadrants. Don't forget about examine this part, renal angle and including the
Spine.
virtuous nodes. Supraclavicular are not completely utilized for GA malignancies, but virtuous nodes is definitely. These are all called as supraclavicular area. Whereas this area is virtuous node, specific area. Already given a homework for right side. Correct.
Thank you, sir.
Any question from the audience? So to summarize, do a meticulous general examination. Leave no stone unturned. That is a very important thing. Even a ecchymosis in the lower limb, a non-healing ulcer, you have to mention to the examiner. So regarding the abdomen, so anemia, very important. It tells you about the chronicity of the problem. Jaundice is telling about the etiology. And then pedal edema, again adds to the liver cell failure. And then don't forget about the markers of liver cell failure, markers of tuberculosis, markers of HIV, markers of malnutrition. These 4 markers is a must in general examination. This don't forget. So in the oral cavity no problem, but these markers are very important. And coming to the general examination, abdominal examination fluid, liver, spleen, right? So other methods of spleen are not that much important, but the examiner may definitely ask. And the other methods you can be very happy that you will get higher mark. You have passed in the routine examination. Routine spleen palpate panni kaamchittom the examiner will move to the higher order question. There are higher order question idellame. So liver palpate repeated திருப்பி room la போய் roommate படுக்க வச்சு காலெல்லாம் மடிச்சு இதெல்லாம் they will forget in the examination. So எல்லாமே தெரியும் எல்லாம் படிச்சிட்டோம் அந்த knee flexion பண்ண மாட்டோம், right? The examiner will note this point. So there is a simple point. This will come only by practice. Another do it repeatedly, you will definitely succeed in the examination. So fluid thrill, sir demonstrate banana, fluid thrill, and then there's a shifting dullness, and then spleen palpation, liver palpation. So the நாலு தான் ரொம்ப இம்பார்ட்டன்ட். நாலு தான் இருக்கு அப்டமன்ல, அது வேற ஒன்றும் கிடையாது. ஸோ CVC is different, அது மர்மர் சவுண்ட் எல்லாமே, ரைட்? ஓகே, ஆல் தி பெஸ்ட்.